When we talk about diabetes and nerve damage, our minds usually go to one place, that slow, creeping numbness in your feet. And yeah, that's the classic story. But what if I told you that's just chapter one? There is a whole other side to this, a collection of sudden, really dramatic, and often painful medical mysteries.
Think about this for a second. It's a total paradox. You've been working so hard, you've finally gotten your blood sugar under control, you're doing everything right, but instead of feeling better, bam, you're suddenly hit with some of the worst pain of your life. It sounds completely backwards, right? But it's a very real scenario, and it kicks off our deep dive into the untold story of diabetic nerve damage.
Okay, so let's get on the same page here. Over on the left, you've got your typical neuropathy. It's what we all know. It's a slow burn, it's symmetrical, meaning it happens in both feet, and it's mostly about numbness. But on the right, that's where things get interesting. These are the atypical forms, and they are a completely different beast. They can show up out of nowhere, often just on one side of the body, and they can bring on just intense pain or serious weakness. Understanding the split is going to be key for everything that follows. All right, let's open up our first case file. This one's called Treatment-Induced Neuropathy of Diabetes, or TIND for short. And this is the ultimate medical head-scratcher, where the very treatment that's supposed to be helping actually triggers a brand new, incredibly painful problem. This quote from the research really gets to the heart of it. The trigger isn't that your control is bad, it's that it gets better, too fast. It's not about if your blood sugar comes down, but how fast it drops. I mean, this just completely flips the script on what we thought we knew about diabetes complications. So, check out this graph. It really shows what's going on. You see how the line is pretty flat, and then whoosh, it just shoots straight up? That steep climb, that is the danger zone. It's where the speed of your blood sugar change becomes the #1 factor, and the risk for this painful condition just skyrockets. So what does rapid actually mean? Well, the research gives us a surprisingly specific number. We're talking about an absolute drop in your HbA1c of more than 2 percentage points, all within a 3-month window. That's the magic number. You cross that threshold, and that risk we just saw starts to climb, and it climbs fast.
So what does this actually feel like for a patient? Well, here's the profile. First off, the pain is just severe. We're talking patients rating it an 8 or 9 on a 10-point scale. It usually shows up in the hands and feet, kind of like you're wearing invisible stockings and gloves. You can also get other weird symptoms like dizziness or stomach problems. But, and this is a huge clue, your muscle strength, your ability to move, is almost always fine. It's like a sensory and autonomic firestorm.
So why on earth does this happen? The leading theory is something called microvascular dysfunction. The easiest way to picture it is this. Imagine all the tiny blood vessels that feed your nerves are like little fuel lines. When your body's metabolism shifts so dramatically and so quickly, it's a huge shock to the system. It can actually damage or clamp down on those tiny fuel lines, basically starving the nerves of the oxygen and food they need to work right. Okay, let's set that file aside and open a new one, because this next case is a totally different kind of mystery. We're shifting gears now from that paradoxical pain to a case of sudden, really debilitating weakness. This one is called radiculoplexus neuropathy. Now, this condition has a very specific playbook. It almost always unfolds in the same order. First, there's a lot of weight loss, often pretty drastic and out of the blue. Then, severe pain kicks in. But here's the thing. It's usually just in one leg or one arm. It's lopsided. And then, a few weeks after the pain starts, that's when the serious weakness and muscle wasting begins. That exact sequence is the telltale sign. And the cause here is completely different, too. What you're seeing is something called microvasculitis. You can think of it like friendly fire. The body's own immune system gets confused and launches an attack on the tiny blood vessels that are the power supply for the nerves. That attack cuts off the power, and that's what leads to all the pain and weakness. But here's what's so unique about this one, the prognosis. It's what doctors call monophasic. Basically, that means it follows a very predictable path. It gets worse and worse for several months, then it hits a plateau and just stops. And after that, it actually starts to get better, slowly but surely, all on its own. It's like the body eventually calls off the attack and starts cleaning up the damage. On to our final case file, and this one involves a totally different mechanism. We've talked about metabolic shock, we've talked about inflammation. Now we're looking at a straight-up mechanical problem. Nerve compression. Welcome to the entrapment files. So why are people with diabetes more likely to run into this? Well, it's kind of a double whammy. First, high blood sugar can make the nerves themselves actually swell up. And second, it can make the tissues around the nerves get stiff and tight. You put those two things together, and you've got a perfect storm where a nerve is much, much more likely to get pinched in a tight spot. And this pinching tends to happen in very specific hot spots in the body. The most famous one, of course, is the median nerve at the wrist. We all know that as carpal tunnel syndrome. Other common spots are the ulnar nerve at the elbow, your funny bone nerve, and the peroneal nerve right at the side of your knee, which, if it gets squeezed, can cause that classic foot drop. Okay, so we've just looked at 3 totally different cases: a pain paradox, a weakness mystery, and a mechanical entrapment. Now it's time to play detective. Let's bring all these clues together and see what the big picture really tells us. This table, this is like our evidence board. It just lays it all out. You see TEND? That's all about severe pain from a blood flow problem, and thankfully it gets better over a couple of years. Then you have reticuloplexus. That's the one-sided weakness from inflammation, and it improves slowly by itself. And finally, entrapment. That's your localized numbness from a physical pinch, and it gets better if you treat it. 3 different stories, 3 different causes, 3 different outcomes.
And that brings us to the most important point of all. Diabetic neuropathy isn't just one thing. It's not a single diagnosis. The pattern of your symptoms, is it sudden pain? Is it weakness in just one leg? Is it numbness just in your hand? Those are the vital clues that point to what's really going on under the hood.
So, if you remember just one thing from all this, please let it be this: do not ignore new, sudden, or one-sided nerve symptoms. Don't just shrug and say, oh, it's just my diabetes. As we've seen, these can be signs of something very different going on, and it is absolutely crucial that you tell your doctor, especially if it's happening while your glucose control is changing. And that leaves us with one last really big question to think about. Right now, we're in this amazing era of powerful new diabetes drugs like GLP-1 agonists that can cause really fast, really big drops in blood sugar. So, given what we now know about that first case, TIND, is it possible that the very success of these incredible new treatments could actually cause a rise in these atypical, painful neuropathies? It's a really important question for the future of diabetes care.